A significant part of my practice is people who come to me for treatment of skull-based problems, and the most common is acoustic neuroma. What is an acoustic neuroma? Well, first of all, acoustic neuroma is an age term that isn't really specific. It really is a tumor of the lining surrounding the nerve that gives you balance, called the vestibular nerve. So actually, you'll see if you go on drgoogle.com, you'll see vestibular schwannoma, you'll see acoustic neuroma. It's all referring to the same tumor. So if you look at a nerve, it's just like a pen, where the outer case of the pen is actually a coating where you've got the moving parts on the inside. So all the work of a nerve is done internally, and these tumors generate from the outer core and compress what the nerve is actually doing to function. And that's where you get the symptoms. And the main symptoms people report is hearing loss. They can have problems with balance and even episodes with vertigo. And when we get concerned is when one side is not in continuity with the other. So if you have hearing loss in one side, ringing or tinnitus in one side, or significant imbalance that comes in episodes, we really want to start evaluating you for all of the causes of hearing loss and balance disorders, but most importantly, to rule out that you have an acoustic neuroma. So how is it diagnosed? The first step is an audiogram and an examination by an ENT doctor. The audiogram will tell us whether you have a sensory or a neural hearing loss. It'll tell us whether you have a conductive hearing loss, and it will tell us whether from side to side, your hearing loss is equal. The next step would be to go through an MRI scan. The MRI scan will typically show an area that enhances or lights up with the contrast agent that's put in. And if it's in the area which we call the cerebellopontine angle, which if you were to take a brain, and I'll show you on my plastic model here, this is the cerebellum, this is the pons, and this is all of the cranial nerves that run your speech, hearing, moving your shoulders, moving your tongue, smell, vision. They all occur in this area here. In the particular area between the cerebellum and the pons, you can generate these tumors coming off of the nerves that you see here. So once the diagnosis is made, typically you're referred at that point to a neurotologist. And a neurotologist is a physician who's gone through medical school, has gone through an ENT residency, and then a special 2-year fellowship just to understand how to operate in this very tight area of anatomy. So when you come in and see me in clinic, we'll typically do a good history. We'll look at your audiogram and we'll repeat that. And the audiogram being the hearing test to be sure that we agree with how it was put together and it agrees with what we're seeing on the scan. Oftentimes I'll put a little fiber optic scope through your nose and look down at your vocal cords to make sure your throat has normal sensation and that the vocal cords are moving normally. People who have hoarseness along with their hearing loss oftentimes have larger tumors, and that would really have an impact on how we approach that either surgically or with radiation. So once we go through that evaluation, we'd have a discussion over your particular findings on scan, on your audiogram, and with any other diagnostic testing that we do to come up with a treatment plan. And what are the various forms of treatment? Well, all of these I would consider treatment. One, depending on the tumor size and location and your medical risk and potential for complication, is to just observe and do another scan, typically at 6 months to a year, to see if the tumor is growing. Overall, these grow roughly at 1 cubic millimeter a year as an average. So observation, we call it active watchful waiting. We would do an MRI scan in a year, get a hearing test in a year, and if any of your symptoms get worse, at that point, we would bring you in for evaluation sooner. The biggest issue that people often have is they'll get worse balance function, and sometimes they'll get twitching or lack of movement in their facial nerve. The second form of treatment is radiation treatment, and it's very specific, computer-driven, either by a cyber knife or by a gamma knife. I collaborate with the Swedish Neuroscience Institute Radiation Oncology Group, and we deliver very high-end care in this area. It's one of the few places in the country where you have a gamma knife sitting right next to a cyber knife, and we let you choose. The gamma knife, you're actually in a tube that rolls through the radiation delivery system with your head held still by either a mask or a frame. And what happens is those beams of radiation come right in and hit the tumor and do minimal damage to any tissue around the tumor. We base this on a CT scan, on an MRI, and this is all put together by myself as a neurotologist, by the radiation oncologist who actually generates the plan. We actually have a physicist whose job is to do the X's and O's in the computer plan to make sure that your care is absolutely optimized to your particular tumor. The other form of radiation is the cyber knife. And what it does is it takes what we call a linear accelerator, and you're sitting on a table and it's imaging with x-rays the whole time that the radiation dose is being given, and it moves around and it hits that tumor at various angles to knock off its blood flow and to kill tumor cells. Typically, if a tumor is not large, and if it's not in a difficult place anatomically, we will watch a patient until they start growing before we do radiation. And the reason is, unlike cancer and malignant type conditions, the acoustic neuroma doesn't go away with radiation. Over time, it actually swells for the first 18 months. We have to be careful that there's room in your brain cavity for that swelling. But then it starts degenerating and shrinks, but never really goes away. So we're not actually ridding you of the tumor, we're trying to stop it from growing. A very low number of these tumors can actually grow through radiation and require surgery, and the complication rate, if you do have growth after radiation, is higher than the complication rate for doing surgery without radiation. So then the last and probably the most intimidating option for people is surgery. And acoustic neuroma surgery is very complex. I've been doing it in our area for over 25 years and have extremely good outcomes. Of the three options, there's two that we use for hearing preservation, and one where we drill through the inner ear and we don't preserve your hearing intentionally. And typically, the translabyrinthine approach is the approach that we use if we're not trying to save your hearing or your hearing's already gone. And so the translabyrinthine approach is one where we go through the mastoid bone just like we would for an ear surgery. And we drill the mastoid open, and that allows us to get into the brain cavity right here. And your tumor is sitting right in this area. So we drill the bone away, do our dissection, and in this particular approach, we take a little fat out of your abdomen and pack this mastoid when we're done to prevent a brain fluid leak. The second approach actually is one where we go retrosigmoid or suboccipital. So instead of going through the mastoid, we come behind the mastoid and we make about a quarter-size opening in the skull. That allows us to come in to this posterior fossa area for larger tumors or tumors that we're trying to preserve hearing that extend much more into what we call the posterior fossa. This is probably the most used approach we have in our practice because it gives us the best look at all of these cranial nerves. So you really want to have visibility on these nerves. So we're very careful about that. And we will actually work back and forth with the neurosurgeon. In the translabyrinthine approach, I do the opening. In the suboccipital approach, the neurosurgeon does the opening. Once the tumor is removed, the neurosurgeon will come in and put a titanium plate there. We put some artificial bone. A lot of people are very concerned that, what if I hit my head? What if I fall in the bathtub? Well, this is so solid that your bone would break before a reconstruction would break. The third approach is what we call the middle cranial fossa approach. We make an opening here in the skull. We gently elevate the temporal lobe of the brain and we drill the bone away to get to that inner ear canal and remove the tumor. This is an approach that's used for small tumors that are mainly in the internal auditory canal. So those are the three surgical options. And what does that look like for you? Well, surgery typically is anywhere from about 3 to 8 hours, depending on which approach we use, the tumor size that you have, and actually the quality of the tumor. These tumors can be I guess the best analogy would be a packet of Swiss Miss mini marshmallows, where you take that marshmallow out and you stick it in your mouth and it gets moist. They can peel off like a wet marshmallow. Then there's tumors that are more inflammatory or they've had radiation. Take that marshmallow, put it in a microwave, zap it, and then try to peel it off the plate. That's what a very aggressive or sticky tumor can feel like, and you'll hear us talking about that. That has implications on outcome and long-term complications that oftentimes we can somewhat predict, but we don't know until we're actually in on the case. So what are the long-term outcomes and what are the complications that we're concerned about? So as with any surgery, bleeding, infection, the risk of anesthesia, they're all very low. Our neurosurgical team, through anesthesia, through the pre-op area, post-op area, the nurses on the floor, the doctors involved in your care, this is our specialty. We are all fellowship trained, board certified, in addition to our basic board certification. So we're very committed to this type of treatment. The big three that we talk about, facial nerve function, hearing, and balance. When we take your tumor out, we actually cut your two balance nerves because they are the source of the cells that generate these tumors. And they also, if they are left intact, they can actually give you more dizziness postoperatively. So we cut them on that side. We rely on your vision and the sensation of touching your joints and in your feet and your other ear to perform a process we call vestibular compensation, which is really the focus of the physical therapy that we provide to get you to recover from your imbalance. The second is hearing loss, and in tumors that are larger than 2 centimeters, the chance of preserving your hearing is less than 50%. If you have any hearing loss that we call serviceable, which means you could actually make words out of sound either with your ear alone or with a hearing aid, we do everything we can to protect that and preserve it. The big one that I always get people focused on is your facial nerve, and that is the nerve that moves your whole face. You can have a little weakness in one branch, since there's 5 branches in your face, or the whole facial nerve can actually go out temporarily or permanently after surgery. Permanent facial nerve dysfunction is very uncommon. It's less than 5%. Typically, I can predict looking at your scans whether you're at risk for that. Any weakness can take anywhere from 6 to 9 months to start healing, and at about 24 months or 2 years after surgery, what you have in recovery from a facial nerve injury is typically what you're going to have long term. Balance dysfunction is just like if you have your knee reconstructed, you do all that physical therapy to build the muscles up around your knee. As long as you do the work, your knee's going to be stable. As long as you do your rehabilitation, your balance is going to be stable. So we lay all this out to you with your scans. I have you get a consultation with our radiation oncology team, so you're fully informed. We are very good at what we do in radiation and surgery, but one of the things we're not ever going to do is talk you into one form of treatment or another. We just give advice, and we respect that this is your body, your medical condition. We need to honor your wishes. Because at the end of the day, we don't operate on tumors. We operate on people who have tumors, and those people have families and they have communities, and that's important to all of us.